All right, guys, I'm going to start. I narrowed down the topic that was given to me. There are a lot of, I felt like a fellow making this talk. There was a lot of fresh slides in this talk, so it was good for me to kind of go through some of this data. I wanted to focus on outpatient therapy for ANCA-associated pulmonary vasculitis. I'm not talking about alveolar hemorrhage because I feel like we've just talked about that and have had several talks on plasmapheresis. Okay, so I have no financial disclosures relevant to this talk. I will be discussing non-FDA approved therapies. Pulmonary vasculitis review, just so we're on the same page. Spectrum of vasculitis, we're going to be talking about the small vessel, although it does seem to also include medium vessel, vasculitides that are made up of microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. So the first thing you're going to need to get over are all of the abbreviations, which I don't like to use, but these titles, names are so long. So there's a move away from names of people who discovered or described these entities to more of descriptive diagnoses. So Wegener's is now granulomatosis with polyangiitis. Shirk-Strauss is eosinophilic granulomatosis with polyangiitis. And MPA, thankfully, has not changed. In terms of manifestations for pulmonary, we include the sinuses, so we will let the ENTs be in on this, but so nasal disease, subglottic stenosis, endobronchial disease, parenchymal disease, pleural disease, and then rare entities such as pulmonary artery involvement. So I used to get and I still probably do, get a little confused by how we classify these. So the overview way of classifying it is looking at primary idiopathic and primary immune complex mediated, and then secondaries. That's on the next slide. So we're again looking at the pauci-immune or primary, some of the primary idiopathic vasculitides. Okay. Secondary would be sort of our classic autoimmune diseases like lupus or scleroderma, and then paraneoplastic infection. However, when you go through why they call it, because I couldn't understand why it was called pauci-immune when there are actually antibodies involved, it's really immunofluorescence staining. So when you're looking at a renal biopsy, it's the relative lack of immunoglobulin and complement deposition. So that's where that name comes from. I think it used to confuse me a lot. Pathogenesis, and this is more, all of this text is more for me because I have a hard time walking through all of this. So there are neutrophils. They have ANCA autoantigens, myeloperoxidase, and proteinase 3, or MPO and PR3, in their cytoplasmic granules. So they're exposed to a priming factor. The example that's given a lot is infection. So the neutrophils are primed, and they release their ANCA antigens either onto the cell surface or in that environment right around that neutrophil. So then circulating ANCA binds to these antigens, the MPO and PR3, and they activate the neutrophils. And this sets off a cascade of inflammation. And eventually, the neutrophils adhere to and can penetrate the vessel walls and cause destruction and release of oxygen radicals, and then can cause tissue destruction. Okay, so the very simplified version, which I prefer, is that there is an insult. The neutrophil, and there's cytokine. The neutrophil is then primed to present these MPO and PR3. So they undergo activation when ANCA binds to those antigens. The neutrophil degranulates and can release reactive oxygen species, and that can cause apoptosis and something called netosis, where you basically extrude the contents, the chromatin, from the cells, and that can also lead to more inflammation. All right, the more complex version, which is a little bit over my head, also includes plasma cells and B cells, and how that may interact. And that, I think, is really important because of when you're targeting B cells with rituximab. So this one looks at a much broader inflammatory cascade and how there's blood vessel and tissue damage. Okay. So organ involvement in vasculitis. This is, of course, an older slide. So for MPA, GPA, and EGPA, pulmonary involvement is common. More than half of the patients typically have some form of pulmonary involvement. In terms of epidemiology, for granulomatosis with polyangiitis, patients and MPA patients tend to be on the older side, whereas for eosinophilic granulomatosis, you have younger and a little bit older proportion. There's no gender predominance. In terms of incidence, what's most common, or what's listed as most common, is GPA, and certainly does have the highest amount of pulmonary involvement as well. Risk factors: silica exposure, potentially smoking, although that's more so in alveolar hemorrhage, and then specific medications. And there's still some controversy over the leukotriene receptor antagonists, specifically in EGPA or Old Church-Strauss. What is Anca? So when you ask for Anca, they do both staining. So you don't have to ask for C Anca and P Anca. You just ask for, that's why you just order Anca. So I start with the cytoplasmic one, because that's easier for me to see. So you have the nucleoli and then the cytoplasm around that, and that is what's immunofluorescent here. When you compare that to P Anca, which is just around the nucleoli, you don't get to see as much of the cytoplasm. So that's the perinucleolar and cytoplasmic. And what's typically associated with the cytoplasmic is proteinase 3, and with the perinucleolar is myeloperoxidase. In terms of those confirmatory, so EIA is how we get the PR3 and test for PR3 and MPO. Much more common, the PR3 in granulomatosis with polyangiitis, whereas the MPO is more common in MPO is more common in MPA, or microscopic polyangiitis. And then in Church-Strauss, you can see actually both. I've seen as high as 20%, as low as 10% are actually Anca negative. So we'll go through the one case. I like to put in something. So actually, when I first started here about, 8 years ago now, I was rounding on the inpatient service. There was a 72-year-old lady who had shortness of breath, fevers, and fatigue. She did have a past medical history of sensorineuronal hearing loss, reflux, CKD, and a GI stromal tumor that had been resected, and non-insulin-dependent diabetes. She had unintentional weight loss, night sweats, right earache, and she was incredibly fatigued, like could not get out of bed fatigued. And she was someone who was previously very active. In terms of her social history, she was a former smoker, and she was a former unit clerk at Henry Ford. On exam, the most remarkable thing was that she was mildly hypertensive. Her rumor saturation was 96. She was mildly, like I said, fatigued appearing. She did have bibasilar crackles, but really no rash, no joint effusions. And I should have put sinus exam, but doing that in the hospital can be a little problematic. So here is her x-ray, which is not a great x-ray, right? It looks like maybe there's some fluid there. It's unclear if there are infiltrates. So she actually underwent chest CT, which was much more remarkable. And so here you can see she has what looks like nodular consolidation. It looks like she has air bronchograms. You could argue that some of these are cavitary, and they do seem to, I don't have the scrolling, but they did seem to follow the bronchovascular bundles. So at the time we were thinking vasculitis, this is a very old slide because I would be saying organizing pneumonia now instead of BOOP, cancer, sarcoid, vasculitis, and infection. So going on with this case, she actually had proteinuria, hematuria, an elevated white blood cell count, elevated inflammatory markers, and a non-diagnostic bronchoscopy, so primarily looking for infection, but transbronchial biopsy was also done. She did, within a few days, had an ANCA that was P ANCA positive 1 to 320 and confirmed with MPO. So the pulmonary consult team was pretty convinced here that she likely had vasculitis. The rheumatologists were not. They felt that she probably had lung cancer and requested that we move towards surgical lung biopsy. We actually talked with the renal service, and she underwent renal biopsy with the plan of lung biopsy if it was non-diagnostic. So she did have necrotizing. She had features of chronic kidney disease and acute kidney injury. So necrotizing and sclerosing glomerulonephritis. Started dialysis and started on steroids. No one was really comfortable putting her on a steroid-sparing agent, and so she walked into clinic 2 months later. I'm not sure how she got to clinic, but she walked into clinic. She looked great 2 months later, and her infiltrates had resolved by then. So what I did was tapered her prednisone and added azathioprine for maintenance therapy, and followed her imaging and PFTs and C-reactive protein. So we'll talk about some of the, maybe what would have ideally happened with her, and how would we treat, and then in terms of induction and maintenance. So for her, she was MPO positive, but she seemed to fit probably more into the granulomatosis with polyangiitis. In terms of the features, she did have pulmonary involvement, renal involvement, and potentially upper airway involvement, because she did have hearing loss as well. And she met the criteria where she had a urinary sediment, she had granulomatous inflammation on biopsy, and fixed infiltrates. The other thought there was that maybe she had MPA. She did have rapidly progressive glomerulonephritis, this acute on chronic presentation, and pulmonary involvement, but typically not infiltrates. If they do have involvement, it can be fibrosis, which might be related to recurrent bleeding events. But either way, what's nice about these disorders is that whether it was MPA or GPA, we were going to treat her in the same way. And in terms of the MPA criteria, just to quickly review, you really can have quite a bit in here, where you have renal involvement, and if you have biopsy, great, but you can have 3 out of 10 of these present. Okay, so moving on to treatment. All right, so this is from the European Society looking at vasculitis, and then the European Dialysis, Renal, and Transplant Associations. And so they came up with their guidelines that were published in the last year. And the newer guidelines from the American College of Rheumatology are being worked on and will probably be published next year, but are probably going to have similar recommendations. So I'm going to walk through some of the data that informs these guidelines. So patients with a new diagnosis of ANCA-associated vasculitis with organ or life-threatening disease are treated with cyclophosphamide or rituximab with a corticosteroid or glucocorticoid. And then non-threatening, non-organ-threatening disease, methotrexate or mycophenolate. So we'll talk about those things. And then in terms of patients who have achieved remission, maintenance therapy involves azathioprine, methotrexate. And then there's the data on the rituximab is still coming, but is what's being looked at. Okay. The other nice thing they did in terms of these, in terms of this guideline, was they actually looked at what doses of prednisone people would get in these trials. And by week 12, by 3 months, patients were on 20 or less. And in most of the studies, you start at 50 or 60 milligrams of prednisone. None went over 80 milligrams a day, except when you were getting your initial therapy with, say, cyclophosphamide, and if you were getting pulse dose steroids in the hospital. Okay, so induction. Cyclophosphamide is a cytotoxic agent. It's administered as a prodrug. It requires hepatic metabolism, and then it is actually not FDA approved for any vasculitis, but it is on the non-FDA approved list for GPA. There are no placebo-controlled trials looking at cyclophosphamide. Yeah.
What's a non-FDA approved?
So Medicare will pay for, the insurance will cover that. It's a Medicare sort of term. And so they do look at that. So if they feel like there's strong data, but it's not sort of what would meet the criteria for FDA approval, or it's not technically FDA approved, but they feel like there's good data, they will put it on that list and it can get covered. Okay. So in cyclophosphamide and ANCA vasculitis, in the early 70s, there was a publication on 4 patients, and this is, when there was nothing else, patients were getting systemic steroids. The ones who didn't respond to that were dying. And so they really did not have anything else. And so when patients were started to be treated with this was a huge change. Many years, decades later, the European Vasculitis study group, they published a meta-analysis looking at pulse versus oral cyclophosphamide, suggesting that there was equivalent efficacy in induction for ANCA vasculitis. So maybe not everybody needs to get pulse steroids, because the mainstay of therapy before was IV Cytoxan, or cyclophosphamide, sorry, I shouldn't use brand names. So in looking at, and this is probably the best name for a study, and they don't even put what it stands for. It is just called Cyclops. So this is cyclophosphamide and I'm not sure of the initials in here, but it is looking at daily oral versus pulse cyclophosphamide for remission induction. And this is specific to Anca vasculitis. So in the pulse group, just to give you an idea, not so that you memorize these details, but for the first 6 weeks you would get IV cyclophosphamide. So every 2 weeks you would get that for 6 weeks total. Then you would get infusion every 3 weeks until remission was achieved, and I'll talk about that in a second. And you would get this for another 3 months after remission was achieved. After this first 6 weeks, the investigators also had the option of just switching to oral completely. And the maximum dose that patients could get was 1,200 milligrams. So they tried to dose limit. So in the oral cyclophosphamide group, patients would receive 2 mg per kg per day, and then until they achieved remission, and then 1.5 milligrams per kilogram per day for 3 months. And they would reduce the dose for all of these based on age and creatinine. So all the patients received 3 months of cyclophosphamide after achieving remission, whether that was oral or IV. Then, after achieving remission, after that 3 months of remission maintenance, achieving remission, they would all be switched to azathioprine, and they'd receive 2 mg per kg per day until month 18, and then they stopped it. And then for their prednisone or prednisolone, the dosing, just to put it in context, is equivalent. Prednisolone just doesn't have to be converted. It is in the active form. 1 mg per kg per day, and they would taper to 12.5 milligrams at the end of 3 months, and then to 5 milligrams at the end of 18 months. So the outcome measure for time to remission was based on the Birmingham Vasculitis Activity Score. You may ask what that is, and I will show you on the next slide what that is. So remission was the absence of new or worse signs of disease activity on the scoring, on the BVAS scoring system, and then less than or equal to 1 item or less has some persistent disease activity, but non-life-threatening. Okay. So what goes into this score are different parameters. So if you have malaise, you get 1 point. But if you've lost more than 2 kilograms in a month, you get 3 points. So they try to weight it based on severity. So if you have a wheeze, you have 2. But if you have massive hemoptysis, you have 6. So the score goes up to 63. Most of these patients were actually in the middle to lower range of scoring. And then just so, because if you add fast, those other scores don't add up to 63, here's the rest of it, which also accounts for renal, ENT, and nervous system involvement. Okay. Other outcomes they looked at were remission at 6 and 9 months, and then the proportion of patients who develop major or minor relapse. And so I'm going through a lot of these definitions because most of the studies follow looking at these parameters. So major relapse is defined as a recurrence or first appearance of more than one of the BVAS items. So if you develop new hemoptysis, that would be a major relapse. Minor relapse would be recurrence of or first appearance of 3 or more non-vital items. So if you have wheezing, a rash that's not an ulcerated or gangrenous rash, and sinus congestion or nosebleed, that would be minor relapse. And then other parameters they look at were survival, change in renal function, adverse outcomes, and then cumulative dosing of cyclophosphamide and prednisone or prednisolone. So patient characteristics, they're pretty similar. I include this to show that about half the patients had MPA, about a third had GPA, and then there were some who had what they call renal limited vasculitis. In terms of results, the patients receiving oral or pulse, they actually had similar rates of remission. And so the oral group is the dashed line here, and the pulse group are the solid black lines. And this is the percentage of patients with remission over up to 10 months. So similar there. The other way to look at this would be their vasculitis activity scores, and those dropped for both groups tremendously within 3 months, and appears to be sustained over 18 months, and were similar as well. The patients receiving pulse dose cyclophosphamide received lower amounts total of cyclophosphamide than the oral daily group. And also had a lower rate of leukopenia. Okay, so this is all, starting to sound like, geez, it's a good argument to give IV, to give pulse cyclophosphamide. So why doesn't everybody go on pulse therapy? What they did is they followed these patients after they finished the study, and then on the retrospective analysis of these 148 patients that were followed for about somewhere between 4 and 4.5 years, they looked to see what happened to them after. So they looked to make sure that the patients received the same amount of steroid and the same amount of maintenance therapy, which they did, so that didn't account for the differences. But what they found was that the relapse rate was higher in the group receiving pulse dose cyclophosphamide. And it's unclear why. It might be related to the dosing, because they do receive a lower cumulative dose. But the hazard ratio of relapse in the oral group was actually 0.5 and had a significant, was statistically significant as well. And so this is why most will get, if they're treated with cyclophosphamide, they're being treated with oral therapy. There's really not a difference in onset of effect. Usually you see some response to therapy starting within 2 weeks, whether it's oral or IV. Okay. And this is that same study looking at what happened to these what happened to these patients. So the hazard ratio for oral versus pulse was lower if you received oral. And then if patients were PR3 positive, so these are the patients that tended to be the GPA or old Wegener's patients. If you were PR3 positive, you had a much higher hazard ratio of relapse over time. And this is sort of broken up looking at that, but basically the patients who have a better survival without relapse. I'm not sure why they term it this way. I think it's confusing to look at it, but higher on this is better. So they less relapse in these patients. So the ones who had the best outcome long-term were the patients on the oral cyclophosphamide who are PR3 negative. Okay. So looking at now other therapies as we sort of move forward, because as Zach Morris will tell me, as soon as you give somebody bladder cancer, you're not given this medication again. So Rituximab. So it is a mouse human chimeric anti-CD20 monoclonal antibody. So it induces killing of CD20 positive cells, which is typically found on B lymphocytes. There may be some found on T cells as well. And it is actually FDA approved for GPA and MPA. Okay. So looking at the Rave Trials, so this is the other major we'll just go through that I'll go through a lot of. So this looks at cyclophosphamide versus rituximab. So all patients for 6 months received rituximab weekly for 4 weeks with an oral placebo, or they received placebo IV to replace the rituximab for 4 weeks. And cyclophosphamide, 2 mg per kg per day oral. And all of the patients received, so those were 2 treatment arms. All of the patients received Medrol 1 gram for 1 to 3 days, so there was some, you had some leeway within there with what was done with the patients. And then prednisone 1 mg per kg per day, and then it was tapered off by month 5 if there was remission without disease flare. And you could switch to azathioprine anywhere between 3 to 6 months. So the maximum cyclophosphamide that anybody received in this group was 6 months, and everybody went by 6 months was on azathioprine as their maintenance therapy. So similar sort of way that prednisone was being tapered, and similar maintenance therapy. And so 99 patients in the rituximab group, 98 in the cyclophosphamide group. And it was intention to treat. Sorry. Mm-hmm. So for PO up to 6 months. Yep. Okay. So looking at the characteristics of the patients, so breaking up what patients had, and so this is why rituximab is not FDA approved in Old Strauss or EGPA, because 75% of the patients had GPA and most of the other patients had MPA. So it's really tested in those populations. Okay. So in terms of pulmonary involvement, about half of the patients had some form of pulmonary involvement. And then in terms of ANCA, most had C ANCA and were PR3 positive, which makes sense because we're saying most of those patients had GPA. And then almost all of the patients were ANCA positive. So the way that they present their data, I think, is interesting. They looked at your ability to wean prednisone. So it's a and I know Zach Morse loves this too, it's a non-inferiority study. So rituximab is non-inferior to cyclophosphamide in achieving remission in ANCA vasculitis. So you were able to wean the prednisone, because if you didn't have remission, you would not be able to wean the prednisone. So there were similar rates of prednisone weaning in the two groups. Okay. So the adverse events, looking at these, in terms of the leukopenia, it was control group is the cyclophosphamide group. You would expect it to be more common in the cyclophosphamide group, but there weren't an increase in adverse events in the rituximab group. So non-inferior in terms of efficacy, no increase in adverse effects. It was shown in a general vasculitis population with GPA or MPA, and then also looked at in patients, another trial specifically with renal involvement. And so those two studies were used to get FDA approval. Okay. So what about eosinophilic granulomatosis with polyangiitis, or EGPA? So looking at the criteria, you need 4 out of 6, and this has a sensitivity of 85% and specificity of 99.7%. I always take that with a grain of salt, because what is their gold standard? It's a group of people sort of saying, oh, okay, I think they have EGPA. So patients with asthma, eosinophilia, greater than 10% of their peripheral blood cell count, of their actually peripheral, it should be their leukocyte count. Paranasal sinusitis, pulmonary infiltrates, which can be transient, vasculitis with extravascular eosinophils, and then nerve involvement as well. So what's come out in the last year, and this is not FDA approved yet in specific to vasculitis, but can mepolizumab be used for EGPA? So it's an interleukin, so it's an antibody to interleukin 5. So interleukin 5 regulates eosinophil proliferation, maturation, and differentiation. And the data in severe asthma with eosinophilia is that it can improve exacerbations and need for steroids. So it's been also looked at now in vasculitis. And the frustrating, I think we all have at least one patient where we feel like they probably have it, but we just can't. They don't meet all of the criteria for vasculitis, or they're very severe persistent with pretty significant eosinophilia and sinus disease, and you're wondering, could they be veering towards vasculitis? So this may open up another area of therapy. So what they looked at in these patients were patients had to have asthma plus eosinophilia, and then at least 2 of the features that can be seen in EGPA. So they didn't necessarily have to be ANCA positive. And what they did was they also set up a way of tapering down steroids. Patients had to be on at least 7.5 milligrams of prednisone a day, up to 50 milligrams a day to get into the study. And then they would wean their prednisone based on how much they were on. So if you're only on 7.5, after the 4-week mark, over the next 4 weeks, the table sort of guides you to get them down under 4 or less milligrams. And so, like I said, there's a steroid taper. It starts at week 4, and the goal is to get patients under 5 milligrams a day. And then you were allowed to be on an immunosuppressant as sort of a maintenance type therapy, as long as it wasn't cyclophosphamide. So if you're on azathioprine, and let's say you're just stuck on lots of prednisone, you failed cyclophosphamide, you just can't stay on, you wouldn't still be on cyclophosphamide. And so patients were treated every 4 weeks for 52 weeks with mepolizumab or placebo injection. Okay. So it can induce remission. It can help prevent relapse better than steroid therapy alone. And so this is looking at the number of patients or percentage with remission. And there was a significant difference between the mepolizumab and the steroid plus or minus azathioprine methotrexate. And that's what placebo means here. The end of the intervention period, again, was at the 52-week mark. The other thing it showed, again, was that the relapse rate was lower in patients receiving mepolizumab. But it's still not great, because you can see this is under 50% or around 50% achieved remission. So it's better than what we can do sometimes with patients who are refractory to cyclophosphamide with vasculitis in the setting of EGPA vasculitis. It can be helpful, and can induce remission, but it's not. It's only about half of the patients, at least in this study, that it's helping. Okay. So in that intention to treat population, so at 24 weeks, there was an odds ratio of remission of 5.91 if you had received mepolizumab. And then the first relapse within that time period was higher in the placebo group, but still there's a high relapse rate. All right. So adverse events. Actually, patients did fairly well in this study. There really wasn't a difference between the mepolizumab and the placebo group in terms of cardiovascular events or other serious adverse events. Okay, so transitioning, so that was EGPA, and we were talking about more severe disease. But what if it's not that bad? What if you don't want to give cyclophosphamide and their disease involvement isn't that severe? So things that have been looked at are methotrexate and mycophenolate. Methotrexate is an anti-metabolite. Mycophenolate does a lot of different things, but basically prevents synthesis of guanosine nucleotides, which are tend to be a little bit more involved in T and B lymphocytes, decreases recruitment of monocytes and lymphocytes, and then suppresses nitric oxide-mediated tissue damage. Okay. Oh, and neither are FDA approved for vasculitis, induction, or maintenance therapy. Okay. So study looking at methotrexate versus cyclophosphamide for induction therapy. So 95 patients were looked at who had MPA or GPA. They excluded patients with life-threatening or organ-threatening disease. Patients with an elevated creatinine, that ends up being a huge reason why more patients are not on methotrexate, or if they just had skin vasculitis. So patients, the goal dose would be 20 to 25 per week, so you'd get titrated up on that, and they would taper off patients at month 12. And this is, again, trying for induction therapy. And then a fairly standard way of using the cyclophosphamide from these other studies, 2 mg per kg per day, and then until remission was achieved, and then up to 6 months of therapy. And then for both of the treatment groups, they received prednisone, which with a pretty standard taper, and that was they attempted to taper off at 12 months. So looking at time to remission, and so looking at the proportion that received remission here on the the y-axis, sorry, I'm slow today, and then looking at months from entry, there was a similar time to remission for methotrexate or for cyclophosphamide. And so the methotrexate is the dashed line, the cyclophosphamide is the solid line. However, there was a longer time to remission in patients on methotrexate if they had pulmonary involvement. And so that's not in this. That's not on this slide pictured, but there was a longer time. And so I think sometimes I wonder if we use it for sarcoid. Why can't we use it for milder vasculitis? But it's because there's a longer time to remission. And then in the next slide, I think it shows relapse can be higher for patients who have pulmonary involvement. Okay. And the relapses that happened in this study in the methotrexate and Cytoxan groups actually what tended to be pulmonary. So it's not out of the question to use. I think most of us still shy away from using it because if the patient develops new infiltrates, it's hard to interpret whether or not that's vasculitis activity or a reaction to the methotrexate. So moving on to looking at mycophenolate for induction therapy. So they looked at patients who could not be treated with cyclophosphamide, typically because they'd been treated in the past. It's a small study, it's just 32 patients, and they looked at using mycophenolate 1 gram BID, and then they would taper at 12 months. They would start tapering by 500 milligrams every 3 months until off, and then those patients received oral prednisolone. So they looked at complete remission, and so 25 of the 32 actually achieved remission, partial remission in another 6 patients, and then 1 did not respond. So it seems like in patients who do have relapse and have reached their maximum dosing of the cyclophosphamide, or had their 6 months of cyclophosphamide, that this could be an option. This was published well before the Rituximab studies, so I think most would now move towards using Rituximab, but this is an option in patients that can't receive both. Relapse. Okay, so approximately 85% actually achieve remission with cyclophosphamides. And we go back to those older studies where you have the most data. However, up to half, maybe more of that, actually suffer some form of relapse, whether that's severe disease, new organ manifestations. It can be any of those. So it seems that when treating most of these patients, most are going to have some form, a good proportion are going to have some form of relapse. So predictors of relapse. So this is a study looking at patients who had to have renal disease to be in the study, but they're ANCA associated. So most of the patients, although it said renal, there's only 88% that had renal involvement. Half of the patients in this study had pulmonary involvement. So in this study, they're again looking at their structure to look at relapse. Their induction therapy involved cyclophosphamide with methylprednisolone and oral prednisone. And they would receive maintenance either with azathioprine, mycophenolate, or cyclosporine. The patients who were at higher risk of having relapse, so in this graph, probability of relapse-free survival. So higher up on the percentage means that you had a lower likelihood of relapse. So the patients who were at higher risk of having relapse were those patients with proteinase 3, who are proteinase 3 positive, had lung involvement or sinus or upper respiratory involvement. The other and the other predictor was if they were given a diagnosis of GPA. But in looking at the odds ratio of having, the hazard ratio of having antiproteinase 3, 1.87 hazard ratio of having relapse. And then for lung involvement, 1.71. So the patients that we're seeing in our clinic tend to have a higher risk of relapse. In patients who had sustained remission, so they looked at how long patients received cyclophosphamide. Because at this time, people were still going past 6 months, and this study helps show that you don't have to treat patients longer than 6 months with cyclophosphamide. The relapse rates were identical in patients who received cyclophosphamide for more than 6 months or less than 6 months. So most have moved towards at the 6 month they're stopping cyclophosphamide therapy. Okay, so we'll talk quickly about maintenance therapy. So if the cyclophosphamide works well, why not leave everyone on cyclophosphamide? So there's the more obvious of the cancer risk and fertility issues are the big ones. But in terms of looking at how patients do with another agent for maintenance, this was a study sort of showing that azathioprine is effective in terms of maintenance therapy. So patients were randomized after achieving remission at the 3 to 6 month mark, and they were continued cyclophosphamide for 12 months, and then azathioprine for 6 months, and then The other group just received azathioprine and prednisone for 18 months. So this is another study looking at alternatives to long courses of cyclophosphamide. So azathioprine is an antimetabolite. It is on the list of non-FDA approved uses for vasculitis, most likely because in almost every study, azathioprine is used as the maintenance therapy. Maintenance therapy was similar. There was a similar time to relapse, whether you received cyclophosphamide for an extended period of time, or if you were switched to azathioprine earlier on and continued as that as your maintenance therapy. So there was no benefit to continuing cyclophosphamide for maintenance. That azathioprine is as good. And then this is another way of looking at it with the vasculitis activity scores. So all of these patients were induced with cyclophosphamide, so we would expect that the scores drop the same amount. But as they stayed similar throughout the study, again, it shows that the azathioprine is as effective as cyclophosphamide in maintaining remission. And then for patients with persistent disease, again, the scores were pretty similar in terms of that activity score. Okay. What was sort of expected is that the leukopenia is worse during the induction phase and a little bit higher in the cyclophosphamide group when it's used longer period of time during the remission phase. And there was a higher number of adverse events in the patients receiving cyclophosphamide for longer. Okay. So next thing, and these are all things that I've sort of encountered when trying to figure out what to put people on. So the other question I had is why, because I love mycophenolate. I think it's a great drug. It's tolerated well, so why not just use mycophenolate for vasculitis maintenance? And some of that is my comfort level, but why is azathioprine preferred? So the rheumatologist will move towards azathioprine. So in looking at a study where they compared maintenance with either one, all patients were treated with cyclophosphamide and systemic steroids, so that's their induction regimen. They received that for up to 6 months, and they tapered off their steroids within 2 years. The azathioprine group was had a dose reduction over an 18 and then 42-month period, and then the same with the mycophenolate group. And they went up to a maximum of 2 mg per kg per day with azathioprine, and for MMF, 2 grams per day. So time to first relapse, there was a difference. It was the percentage was higher in patients with mycophenolate, and it was a shorter period of time before they had their first relapse. Okay, and then looking at their first major relapse, it's maybe a little bit worse than the mycophenolate mofetil group, but it's unclear in terms of statistical significance. So the reason to favor azathioprine over mycophenolate is that the time to first relapse is better when using azathioprine. There was no difference when they looked at adverse events in these patients. There was really no difference. And then looking at alternatives for GPA remission maintenance, azathioprine versus methotrexate. In looking at 126 patients over 12 years, all of the patients again received cyclophosphamide and steroids as induction, and then they were randomized when they reached remission. And so they looked at azathioprine, similar dosing as in the last study, versus methotrexate, where they would get up to a dose of 25 mg per week, and they gave that for only 12 months. So this is a shorter duration. There really was no difference in overall survival in the two groups, whether they received azathioprine or methotrexate for maintenance, and whether they had MPA or GPA. The survival is actually pretty similar. When they looked at relapse-free survival, it was not statistically significant, the difference between the two groups. So they're looked at pretty equivalent. So you will see some patients started on methotrexate as their maintenance therapy. Okay. What about rituximab? So we talked about using it for in induction therapy, but can it be used for maintaining remission? So there have been some, the retrospective study that was done looked at least 4 weeks of dosing, and then, weight-based dosing for 4 weeks or fixed dosing for 2 weeks. And in this regimen, which you could argue is short based on the other studies that are done, 50% relapse rate, compared to only 30% in the patients who receive rituximab for induction with methotrexate or azathioprine. So based on this study, using that short course of rituximab up front doesn't help in terms of preventing relapses. Fine for induction. Another study looking at giving rituximab every 6 months for 2 years. They actually had a little bit lower relapse rate reported, which was 42%. And then finally, there's a trial that's being done now looking at achieving remission using rituximab, achieving remission and maintaining remission using rituximab or rituximab then azathioprine. And that'll look at 3 years worth of time. And so that study's not out yet. That study's being planned and being done now. And so the hope is that if patients do well on rituximab, potentially they can just use that as their maintenance therapy, spaced out to twice a year even. Okay, I think I'm almost done here. In summary, so I went through a lot of data, but the takeaways from all of this is that systemic steroids and cyclophosphamide, or systemic steroids and rituximab, are effective in achieving remission in patients with organ or life-threatening disease. In patients who can't receive cyclophosphamide or rituximab, I think you also have the option of mycophenolate for induction therapy. When patients have milder disease, methotrexate is also an option, but this does have substantial pulmonary-related relapse. For maintenance therapy, azathioprine provides a longer time to first relapse than mycophenolate, so that would be preferred. Azathioprine and methotrexate were relatively equivalent in efficacy, but that was only looking at 12 months. And the studies vary in how long, but most err on the side of 18 months up to now 2 years in terms of maintenance therapy. But it's not great data for that. And then the predictors of relapse are the patients we should probably have a little bit more awareness of potential for relapse are those patients with upper respiratory or pulmonary involvement, patients who are PR3 positive, and then GPA, rather than just this renal-limited disease. Okay. I'm happy to take any questions. Yes, Sal.
When you talk about therapy,
Yes.
when comparing rituximab to other agents, is that without any steroids?
No, they still will use steroids up front. They still typically use steroids in the early part of disease treatment, but they would taper off steroids much faster than you would it with cyclophosphamide, or you can taper it off faster than with cyclophosphamide. Yeah.
Last couple of slides. The study when you...
Which one? This one? Okay.
Yeah,
Okay.
So when you compare rituximab to the other agents for maintenance therapy.
The goal would be to bring the steroids off much faster. That's just from the experience that people have with with autoimmune disease. That typically 4 weeks after the second infusion, we find that we're able to. But in terms of this study, I'd have to look at specifically how fast they taper off. But it's typically less than 3 months that patients are able to come off the steroids, would be the goal.
So I define my patient as in remission. They are on steroid.
They can still be on a steroid. Yep, it's based on their. You can still be on a steroid. It's based on disease activity. Yes.
For the cyclophosphamide, if you have a younger patient and you're worried about they still want to potentially get pregnant or have children later on in life, do you just go to rituximab for induction, or do you just start talking to them about?
I think it depends on severity of of disease, most will try to get them on rituximab, but, and now that that's FDA approved, you have a higher likelihood of being able to get that. But for some of the patients, because their disease is not that severe, that may actually buy you time to do egg harvesting, like a cryopreservation type stuff. But if they have life-threatening disease and they can't get rituximab, that really is just the hepatitis, that specific hepatitis serology. They would probably not be able to get cyclophosphamide either. And so typically you try to go with the rituximab. And then if it's milder disease, I've seen methotrexate, and then I've seen methotrexate and mycophenolate be used, but mostly methotrexate.
And you talked about in your talk that after the 6 months period, so after that 6 months period, so let's say they run cyclophosphamide, do they usually lose all fertility function, or do they
And it doesn't come back. If they lose it, it doesn't typically come back.
My big dilemma is after you treat them for a couple of years, they look like they're cured, they're off therapy,
Right.
they're off therapy for 2 or 3 years after that, doing great. And then, what these studies never address, what dilemma we often face, we check the ANCAs on a regular basis, and then 3 years later, the ANCAs turn positive again. They're not sick at all, they're feeling fine.
Right.
You certainly don't meet the criteria for a Rituximab relapse, they're not pound the crap out of them with that anymore. So, what I've been doing, and I don't know if it's right or wrong, because nobody's ever written about it, is I'll just put them on a little low dose of Methotrexate or azathioprine or something, and all seem to get better, but then you're kind of stuck for life at that point with just keeping them on it.
So you're saying, so they have evidence of clinical activity besides the ANCA?
No, I never wait for them to get sick. If they've been negative for 3 or 4 years and their ANCA's like 1 to 40, 1 to 80, 1 to 60, I'll just start treating them. I'm not going to mess around, wait for them to crash and burn.
Yeah, no, I'm not sure, Zach, because I know for the PR3, if that's still positive, persistent, then
But if it's been
more
negative for 3
aggressive,
or 4 years,
If it's been negative and then recurs, they are at higher risk of redeveloping or having a relapse, or, but I don't know if everyone treats empirically.
Like I said, nobody ever addresses it.
Yeah.
I treat them, put them on low dose and this negative.
No, there's documented risk too, that they can relapse, but I don't know that it's gone further than that, but I can look. I'm not sure.